All right, I'm going to go ahead and get started. Once again, I want to thank everybody for joining us this Tuesday evening. For those of you who don't know me, my name is Jan McAlister. I'm a DNP and lipid specialist at Piedmont Heart Institute in Atlanta, Georgia. I am also the president of the Southeast Lipid Association. And I am going to introduce our speaker for tonight. I am so excited about this talk. For anyone who was at the CLU, this was presented at the CLU. And Dr. Bond, I was blown away. I think just such valuable information for our female population. And I know here in Atlanta, we have several women's screening programs and are really raising the awareness for women in heart disease. So I'm very excited that you were able to present this for our C-List Speaks. I'm just going to give a little background. Very impressive bio. I'm not going to read everything that was on it. And Dr. Bond, whatever you want to add, by all means. But Dr. Bond is a board certified attending cardiologist in Arizona who has really developed her career in the treatment of heart disease through early detection, education, and prevention. She's a women's heart health and prevention specialist and the author of several review papers referencing maternal health, sex, and gender differences in cardiovascular conditions that predominantly affect women, along with opinion pieces aimed at addressing health equity, reducing health disparities, and promoting the professional development of women and minorities in the health science profession. She has a passion for advocacy of education and mentorship and has advised as an expert source through news and media outlets. And Dr. Bond, I am so excited. She's going to talk to us about pregnancy, lipid effects, and ASCVD risk management. If everybody but Dr. Bond would please mute your microphones. We are going to have her slideshow for the next 30-40 minutes. Then when she's done, we will have time for question and answer. We do have a hard stop at 8 o'clock. You can either write your questions in the chat or you can unmute your microphone towards the end and ask your own questions. And I look forward to some excellent dialogue. So, Dr. Bond, thank you again. And I'll talk to you with the questions.
Oh, perfect. Thank you so much. And thank you for the invitation. I'm really looking forward to tonight's talk. So as mentioned, I am currently in Arizona, where I oversee our women's cardiovascular program from a system-wide directorship. I also volunteer my time quite a bit with a lot of the cardiovascular societies, including the American College of Cardiology, the American Heart Association, and the Association of Black Cardiologists, where we've really, I would say, tried to move the needle when it pertains to that interconnection between maternal health as well as cardiovascular health. So I was very, very encouraged when the National Lipid Association had asked me to give this talk, because I think that oftentimes we don't always think about lipids during pregnancy, and more importantly, the effects that the lipids could have during pregnancy on one's future cardiovascular health. So I hope with this talk you understand that a little bit better, so I have no relevant financial disclosures. The objectives for tonight's talk are 4. So first one is the management of lipid disorders in women and the fact that it does require perspective of ASCVD prevention through a woman's lifespan. Number 2, the role of pregnancy and hyperlipidemia and the unique challenges that that does actually pose. Number 3, the change of lipid levels during pregnancy and how this may have consequences on not necessarily just the mother, but also the child. And then lastly, management options to consider for our higher risk mothers during pregnancy as well as breastfeeding. And I think it's really important for us to first begin the topic of discussion with the clinical vignette. So the first clinical vignette, or the only, I should say, clinical vignette, will be a 20-year-old Black female. This is her first pregnancy. She's presenting at 12 weeks gestation. When in taking a very detailed medical history, we find out that her body mass index is 20, which is in the normal range, as we know. She has irregular menses, a family history of premature CAD, father having an acute myocardial infarction and sudden cardiac death at 40, paternal grandfather having the same, but at the age of 50. And when we look at her lipid panel, we see that her total cholesterol is 250, triglycerides are 250, her HDL is 30, LDL cholesterol is 170, and ApoB is 130, and Lp(a) is very elevated at 120. So as we go through this talk, at the end, we will return back to this clinical vignette, but I want you to think about this particular case, because this is a very common case that oftentimes one would ask, what do we do in this situation? Now, it's important first to actually understand what occurs with the lipid panel, and more importantly, cholesterol during pregnancy. And we know that during normal pregnancy, there are a series of physiological changes. First and foremost, the physiological changes beginning in the 2/3 of gestation. So the beginning of that pregnancy, oftentimes it's a anabolic phase. The purpose of that is that we want to have the mother increase that adipose tissue to help the fetus that's growing, because they need that adipose tissue. So that oftentimes includes an upregulation or possibly even a stability in lipoprotein lipase. So as a result of that, there's a breakdown of triglycerides in the bloodstream, but all of that adipose tissue, also through hyperphagia, moms becoming, having a larger appetite, directs all of that to the tissue, to the fetus. And then once the first 2/3 of gestation actually pass, in that last trimester, that's where we see the opposite. And the opposite oftentimes occurs because there's also an increase in estrogen levels, and there's also oftentimes an increase in insulin resistance. And all of that then leads to a decline in that lipoprotein lipase, and as a result, there's more triglycerides in the bloodstream. So it's not uncommon that it's not until even the later phases of gestation that we begin to see a higher number of triglycerides, a higher number of VLDL and LDL. And as a result of that, it's important that we understand what happens normally. To that same point, when we think about maternal hyperlipidemia, it is one of the most consistent metabolic changes that occur through all pregnancies. And oftentimes it can begin as early as the 12th week, not in saying that, again, it's the last trimester where we see the greatest effects, but it can occur as early as 12 weeks gestation. And what we oftentimes see by the end of the pregnancy is that the total cholesterol can actually increase sometimes by 25 to 50%. LDL cholesterol can increase by as much as 66%. From a triglyceride perspective, this can increase by about 1.5 to 3-folds that of what we would normally see outside of pregnancy. And with that, we have an increase in smaller, denser LDL particles that, as we all know, are more atherogenic. HDL cholesterol can increase, but this is peaked typically during the second trimester, where thereafter it goes back to the typical levels that it were outside of pregnancy. And then when looking at ApoA and ApoB, both can increase significantly, 32% or 56% during the second and third trimester. And interestingly enough, Lp(a) as well can increase with increasing gestational age. And I'm going to go back to Lp(a) because I think that this is an opportunity for us in pregnancy to utilize Lp(a). We know that as it stands right now, we're really trying to kind of garner more research outside of pregnancy in terms of pharmacotherapy management of it. But now we're even seeing that with pregnancy, Lp(a) could wreak havoc and oftentimes increase risks of adverse pregnancy outcomes, possibly like preeclampsia, which I'll be getting to. Now, this diagram here very nicely kind of demonstrates what I have already said, which is that following conception, there is a notable decrease in triglycerides in the bloodstream. And a lot of that, again, has to do with the fact that the conservation of adipose tissue is really centered on that fetal growth. The total cholesterol and LDL cholesterol also have a nadir at the second gestational month. But then thereafter, these levels can increase and they oftentimes peak at delivery. it's important to acknowledge that it's normal again to have an increase in both triglycerides and cholesterol. But when those levels exceed greater than 250 milligrams per deciliter, that's not normal. And that's where we then have to decide, are the levels high enough for treatment? Is the patient high risk enough for treatment? When we think about total cholesterol and triglyceride levels in women, as noted, we do not want them both to exceed above that 250 milligram per deciliter range, because in the event it exceeds that 95th percentile, it's not only a risk for the mother, but it's also a risk for the fetus. And we'll get into what that risk looks like. Before we get into that risk, the way we best define women who, when their cholesterols are checked during pregnancy, have evidence that it's above, again, that 95th percentile. The term is coined maternal supraphysiological hypercholesterolemia. So in women who may have significant undiscovered dyslipidemia prior to pregnancy, either as a result of a genetic disorder or possibly underlying medical conditions, it's really important to understand that they can have an excessive increase in their levels. And it's also important to think about the underlying cause as to why. So as I made mention of, sometimes there are conditions that we may not be aware of until the pregnancy occurs. This could include diabetes, obesity, perhaps they had a history of alcoholism, thyroid disease, liver disease, kidney disease, polycystic ovarian syndrome, we know obviously plays a large role. From a medication perspective, we also need to do and take a very detailed history as to determine had they been more recently on corticosteroids, beta blockers, which largely can increase levels of triglycerides, diuretics, tamoxifen, or even antipsychotics. So just as we would in patients outside of pregnancy, we want to do that detailed history. We want to figure out, are there any alternative things that are causing the cholesterol to be excessively elevated above that 95th percentile? And then we want to think about the genetic aspects of it. We know that, of course, familial hypercholesterolemia is a lot more common than we once thought. Particularly, it's more common than genetic disorders routinely screened for in pregnancy. Of course, FH is not routinely screened for. When we think about heterozygous FH, we know the statistics show that it's about 1 in 250 people who have it. And to date, there really are no recommendations for routine FH screening, specifically during pregnancy. And prevalence is really not known about lipid levels because, again, to date, we don't routinely check lipid levels during pregnancy, and there are no guidelines as to suggest when we should, how often we should. But we know in a select group of people, there at least have been some anecdotal evidence to suggest that there should be a trend in frequent checking, depending on what the levels are once the levels are actually accessible. And when we think about FH, because I think it's important because we know that more and more women are having children, but to that point, they're either having children later on in life, or they may have more of these cardiometabolic risk factors and perhaps even go into the pregnancy as a higher risk patient. But also to that point, although there are no actual screening suggestions for FH, we are diagnosing it, I believe, because the public is more aware of it, but also because us as physicians and clinicians are more aware of it. So think about women with FH. We know that when it comes to women with FH, they can show relative changes in lipids that are similar to those in non-FH women. What I mean by that is that the levels may be the same in terms of the increase. It's just that the absolute increase is greater because they're starting off with a much higher cholesterol level, kind of entering the pregnancy than not. And oftentimes, as we know, has been suggested in the past, for women who know they have a diagnosis of FH, the guidelines have suggested stopping statins 1 to 2 months before conception. I'll get into an area where there should actually be more of a shared decision making based on one's risk, because that is what the new suggestions are. But at least in the past, which were not the far past, the suggestion was to stop it 1 to 2 months before conception. But it's important to highlight that it's the absolute increase in the LDL cholesterol that is largely different. It's not necessarily the relative changes that we see. And despite the markedly higher LDL cholesterol levels in women with FH, interestingly enough, the incidence of adverse pregnancy outcomes such as prematurity, low birth weight, even congenital malformations, they don't largely differ. What does differ is maternal hypertension and the incidence of that, where we see that it's greater for women that have dyslipidemia versus those who don't have dyslipidemia, both before pregnancy and, more importantly, once they become pregnant. So it's really the hypertensive disorders of pregnancy that show the greatest difference, not the other alternative adverse pregnancy outcomes. And to that same point, when the cholesterol concentration exceeds that 95th percentile, we know oftentimes there is a predisposition to oxidative stress. This stress is not just at the level of the mother, but it could also be at the level of the fetal vessels. This could expose the newborn to greater fatty streak formation and a higher risk of atherosclerosis. And it could actually cause genetic programming, which would then mean in the future, they're more predisposed to a lot of the cardiometabolic risk factors, obesity, hypertension, and of course, hyperlipidemia. Additionally, when it comes to the mother herself, we know that elevated levels of maternal triglycerides can actually predict macrosomia, and that's independent of other maternal factors such as BMI or glucose levels, which we oftentimes commonly think more so. But to that further point, maternal supraphysiological hypercholesterolemia also makes the mothers more prone to preterm delivery, gestational diabetes, and again, preeclampsia. And when we think about women with preeclampsia, we know that there has been, as I had made mention earlier, a correlation to those women having higher rates and higher numbers of Lp(a). And similarly, women who have higher rates of stillbirth also have, or at least we've been able to see anecdotally, that they have higher levels of Lp(a). But what do we do with that is the question, but it really garners the fact that we do need more research, because I will say that our understanding and appreciation of the full scope and implications of dyslipidemia in pregnancy on both the mother as well as the fetus is not complete. But again, with these patterns that we're seeing and with the fact that they are leading to these adverse pregnancy outcomes that are not impacting them just during their pregnancy, but well beyond, as we know, preeclampsia, as an example, can impact one up to 40 years after delivery in terms of the maternal impact. And of course, the fetal impact is there as well. We really do need to kind of understand what this dyslipidemia that we can oftentimes see is doing, not just during the pregnancy, but also in the long run. There's also another very interesting topic of discussion that I think also really warrants more research. And when I was growing up, really loved childhood stories. And I always remember having my parents read to me Goldilocks and the Little Bears. So we know that the way Goldilocks kind of ventured into the cabin of the three bears, she decided to try their bed, the table, and then the porridge. And the porridge was either too cold, too hot, but then she found that one of the porridges, which were the baby bear's porridge, was just right. And when we think about hyperlipidemia, particularly as it pertains to conception, or at least antepartum period, we know that oftentimes having even too low a triglyceride or even total cholesterol level, more importantly, can actually also increase their risk of adverse pregnancy outcomes. And this was seen in a very large multi-center longitudinal observational study. Many of you are probably very well versed on this study. It was an observational study called the Coronary Artery Risk Development in Young Adults, or the cardiac cohort. This cohort actually looked at a very large percentage of African American women, 49% to be exact, and the average age was 24 years. And what they noticed was between pre-pregnancy lipid levels and other risks of preterm birth in women who were either normotensive, non-diabetic, and otherwise healthy, they saw that women before pregnancy who had total cholesterol levels that were low, and the way they defined that was less than 156, or high, which they defined as greater than 195, had the highest incidence of preterm birth, and that was oftentimes between 34 to 37 weeks gestation. This was independent of race. It was also independent of body mass index and parity. And it demonstrates again that maybe we do need to have the levels just right for these women, particularly during their conception. And why is this important? Because if we're now beginning to have conversation about continuing medications and pharmacotherapy for the highest of high-risk women, is it also safe in the for instance of what the impact could have during pregnancy? Because do these mothers require a little bit extra elevation in their total cholesterol and their triglycerides? And it's important to realize that this study only saw this correlation with total cholesterol. Oftentimes they noted that the triglyceride concentration didn't necessarily show a significant difference, but the greatest adverse pregnancy outcome that they saw ultimately was the preterm birth for women, again, who had either low total cholesterol leading into pregnancy or high total cholesterol leading into pregnancy. And again, it just warrants more opportunity for research and a more emphasis on that connection. Now, when we think about lipid screening, as I said right now, current practice does not routinely include it in testing, not just during pregnancy, but even preconception. I oftentimes, because I direct our women's cardiovascular program and I have a cardio obstetrics team that I work very closely with, anytime I'm referred a patient for preconception counseling, of course, I check lipid panel. However, it's largely not routine. The National Lipid Association has supported checking lipids routinely if there is no normal current one that is evidence pre-pregnancy. And a review did recommend measuring lipids at the first visit, and if it's normal, at the beginning of the third trimester. Again, not guidelines, but at least based on data that has supported this. For high-risk patients, they were suggested to have their lipids measured at the first visit, the beginning of the second trimester, and monthly during the third trimester. And if their triglyceride levels are greater than 250 milligram per deciliter at any time, the lipid panel should be measured on a monthly basis. The premise behind that is that we oftentimes worry about experiencing pancreatitis. And we know that in many of these women that triglyceride levels are greater than 500, they're at a higher, much higher risk of pancreatitis. Pancreatitis in of itself could be very dangerous, but with pregnancy, it could be deadly. So as a result of that, anyone who has triglyceride levels greater than 250 at any area, when you find them during that antepartum period, it is suggested that on a monthly basis, you're counseling them, you're checking them, and we'll talk about what the counseling should look like. The checking of more specialized biomarkers and advanced lipid profiles during pregnancy is not defined like the LP little a and the ApoB and A, but again, further studies are required. So then we talk about the treatment, because obviously once we see that there is an issue, that there's dyslipidemia, we have to obviously address treatment. And largely the first step and the cornerstone is always addressing lifestyle modification. It's with pregnancy, it's without pregnancy. So when we think about lifestyle modification, we want to counsel these patients on what a heart healthy diet actually looks like. We know that includes vegetables and fruits and whole grains and legumes, healthy protein sources, and obviously having them limit any sweets, sweetened beverages, and red meat. And I wanted to highlight just this graph alone, because if we were to actually suggest to our patients that they had an ideal cardiovascular diet or nutritional evaluation where they drop their saturated fat, they ensure that their dietary cholesterol was less than 200 milligrams per day, they had an increase in plant stanols and sterols, and they had obviously a good amount of fiber and soy and almonds, and they worked on, even if they have a history of being overweight or having obesity, they lost 10 pounds. All of that collectively together can actually drop your LDL cholesterol by 30 to 45%, which is sometimes, as we know, equivalent to some of our statin therapies out there. So I would strongly encourage, which I always do, both preconception and antepartum, that they are focusing largely on a heart healthy diet. To that point, we now are actually studying a lot of diets as it pertains to the adverse pregnancy outcomes that we see. As an example, preeclampsia, which we know is a very common adverse pregnancy outcome that oftentimes leads to severe maternal morbidity and not only affects them from a cardiovascular perspective during pregnancy, but also in the future. Lots of data has supported that the utilization of a Mediterranean diet can decrease the risk of preeclampsia because it's anti-inflammatory. Beyond diet, though, particularly for patients who have dyslipidemia, we also want to encourage exercise that could be adapted to pregnancy. And similarly, the suggestion goes with adverse pregnancy outcomes. I'm always suggesting to my patients that we encourage them to do at least 140 minutes of moderate physical activity per week, because that decreases the likelihood of dyslipidemia and thus decreases the likelihood of adverse pregnancy outcomes. And it's important that at every stage of maternal health in the maternal health continuum, we're expressing the importance of nutrition and physical activity, preferably preconception, but absolutely during the antepartum, and most importantly, also postpartum as well. But there are situations where, as we know, even outside of pregnancy, physical activity and diet are not enough. Situations where lifestyle may not be enough. And this is where we will talk a little bit about the treatment options that we have to date. As we know, outside of saying that diet and exercise may not be enough, oftentimes we always start with statins. They've been around the longest, we've studied them the longest, and we've seen exceptional benefits with the use of statin therapy. As it stands right now, statins are first line for hypercholesterolemia in the general population, but as noted, even with our cholesterol 2018 guidelines and the prevention guidelines of 2019, it has not been recommended or encouraged during pregnancy. The recommendation has always been to stop 1 to 2 months before conception and not to utilize it with lactation. But given the lack of clear evidence on the teratogenicity of statins, and oftentimes there was concern about congenital anomalies and malformations, in July of 2021, the FDA actually requested the removal of the strongest recommendation against using statins during pregnancy. It went from a previous category X to now being not categorized. And what they often and actually said was they could continue, and of course they continue to advise that the use of statins in pregnancy, because of limited data and quality of information, should be limited. But the decision really should be a shared decision amongst the provider and the patient. So in those high-risk groups, such as women who have known FH, are diagnosed possibly with FH during pregnancy, which sometimes could be challenging, or even who have a prior history of ASCVD. And we know that the most important utilization of statins from an ASCVD perspective would be if the event was within 4 months, and the continuation of the statins within that first 4 months are so important. Then the consideration would be to continue it. And it's important to highlight that this is not a small, substantial portion of the population. Even when we think about ASCVD, about 1.4% of women between the ages of 20 to 39 have experienced it. And that, I would say, is rather a large portion when you think about the kind of the consequences of what the withholding of those statins could have. And we are actually looking at this data, even from an FH perspective, because many would say, well, we're holding it for 9 months, possibly maybe 2 years if they decide to breastfeed. And of course, we know that there's several benefits in breastfeeding, but data does support that even those episodes where we briefly hold that statin, in the long run, it actually can lead to worse outcomes. So this is, again, where shared decision-making is important. And as a result of that, and as a result largely of the FDA kind of removing the strongest category, we're now actually looking which statins are safer. And we know that right now, hydrophilic statins likely have been safer. They've been shown from our perspective to have a less transplacental transfer. And as a result of that, those are usually the statins that are suggested to be continued if, again, the risk of holding the statin is deemed higher than the benefit of discontinuing it. But now we're actually studying particularly more lower potency statins that are hydrophilic, such as pravastatin. And pravastatin has, I would say, in the past has had kind of either conflicting data, but also data kind of gearing towards the fact that we just need larger studies. Pravastatin back in the day was thought to potentially decrease the risk of preeclampsia. When we talk about preeclampsia, of course, we don't largely know the actual cause of it, but our understanding is that it's due to largely from the placenta and endothelial dysfunction. Understanding that these statins help to decrease inflammation, they lead to better and reduction in oxidative stress. It makes sense, at least in my eyes, that they may benefit or at least help to prevent preeclampsia. And to date, we don't have any mechanisms that prevent preeclampsia. We have management that can decrease the risks. I mentioned the Mediterranean diet, I mentioned exercise, and we know that there's a lot of data to support the initiation of low dose aspirin between 12 to 28 weeks gestation or before 16 weeks gestation in moms who have higher risk factors to proceed in getting preeclampsia. But to date, we don't have anything that could prevent it. So after there was a series of small pilot studies, a larger study, which is still enrolling and began enrollment in 2019, called Pravastatin to Prevent Preeclampsia, was created. This is a randomized multi-center clinical trial. They actually have a total of 1,550 women who have had a prior history of preeclampsia that require delivery before 34 weeks, who are currently at gestational age, and the randomization was between 12 to 17 weeks gestation. They were randomized 1-to-1, either 20 milligrams of Pravastatin daily or an identical appearing daily placebo. And the outcomes that we're looking and hoping to see are: one, primary outcomes, the proportion of participants with composites of preeclampsia, fetal loss, and maternal death. And the secondary outcomes will include preterm delivery, the transition from preeclampsia to preeclampsia with severe features, and any gestational hypertension or gestational diabetes. So I'm very excited to see the results of this, but I'm also, more importantly, very hopeful that we're actually studying the interconnection and sort of that connection between lipids, anti-inflammatory markers, and how we could reduce adverse pregnancy outcomes. But the gist of this is that for statins, they removed, again, the strongest warning label. Most pregnancy patients should still stop it. But again, the caveat is for those higher risk patients, moms with FH or known ASCVD, particularly ASCVD, where the event was within that 4-month period, there should be shared decision making. Let's talk a little bit about our other lipid lowering therapies, because we have obviously so many out there on the market. Ezetimibe has been classified as category C. The recommendation is to discontinue 4 weeks prior to conception, and it's not suggested during lactation. And then we have our newer agents like the PCSK9 inhibitors, either in the form of evolocumab or alirocumab, or even the small interfering RNA such as inclisiran or Leqvio. Although these newer agents have not been tested for safety during pregnancy and lactation, I can say a little bit about inclisiran. It has been studied in animal models, and they have not necessarily seen any negative or hurtful effects to that point, because inclisiran, as you know, after the first 2 doses are given every 6 months, there is a lot of information and data to suggest, would that be an ideal agent to utilize, understanding that it's once every 6 months, a pregnancy being 9 months. Would that provide a little bit more flexibility, particularly in our higher risk patients, those FH patients and patients that have ASCVD? To that same point, we now know that the FDA has also approved inclisiran for patients from a primary prevention perspective, particularly when they're either on the highest tolerated dose of statins or intolerant to statins and are still not reaching levels that they should. So I think, again, that this highlights that more research really needs to be had with these particularly newer lipid lowering agents. The same could be said for bempedoic acid, where we know it's a prodrug that gets activated, however, has not been tested for safety during pregnancy and lactation. Fibrates. So I talked a lot about the concern about the triglycerides. And as noted, when those triglycerides get above 500, that's when the biggest concern lies. So if, despite lifestyle modification, there are women who have triglycerides greater than 500, in the second trimester, after embryogenesis has sort of finalized, we can actually consider placing patients on fibrates. It's not suggested in breastfeeding, but again, if despite lifestyle modification, including nutrition, exercise, ruling out the thyroid and ruling out other things that could somehow impair or impact triglycerides, such as medications and such, then the suggestion would be to initiate this, but again, after the second trimester. And similarly, niacin, it's class C, so should not be used during pregnancy or lactation. Many mothers come into pregnancy sometimes with omega-3 fatty acids. I will say that I've seen many people, particularly that have undergone fertility measures through either in vitro fertilization or other fertility measures that sometimes they're on omega-3 fatty acids. Omega-3, it's widely used, but we really don't have any controlled clinical trials during pregnancy. And as a result of that, from a cardiovascular protective effect, I don't often recommend the ongoing use of it. I will say that our prescription omega-3s like icosapent ethyl has not been approved for pregnancy or lactation, largely because they really haven't looked at the safety profile for it as well. And then, of course, we have the bile acid sequestrants, which are oftentimes the ones that in the past we've always thought to be the safest. And although it is, we know that there are a lot of cons that comes with the utilization of this particular medication. So these bile acid sequestrants, such as cholestyramine, it can be used, again, to lower cholesterol during pregnancy as well as lactation, but we have to also think about the several GI side effects that occur with it, like constipation, heartburn, bloating, stomach pain. We also know that it can elevate your triglycerides. So if we have a patient who has both elevated LDL cholesterol and elevated triglycerides, you have to be very thoughtful of that because it's not suggested for use when the triglycerides are greater than 300. It also can reduce absorption of certain medications. So we just have to be mindful of that and make sure that we're looking at our patient's medication list before prescribing it. And then, of course, in our patients that have significant atherosclerotic disease or FH, typically in the form of homozygous, the option of plasmapheresis and lipoprotein apheresis is safe with pregnancy. It's also safe with lactation, but again, it's oftentimes not suggested. Or oftentimes, I shouldn't say not suggested, but oftentimes first line. But in certain situations, again, with those high risk patients, it may be suggested because there's no other options. I bring up again this diagram because I think it's important that we, again, not just necessarily think about this during pregnancy, but also, even more importantly, the postpartum, where discussion should be had about lactation. Discussion should be had about contraceptive measures, particularly if the patient is going to be placed on these medications and there's a theoretical risk that they could become pregnant again. And I will say that we really do need to use the postpartum period to talk about optimization of health, especially when these women have adverse pregnancy outcomes. We know that a lot of data supports that when we don't have a reduction in even something like weight, particularly the baby weight that many of these women gain during pregnancy, with the goal to get back to the preconception weight, they're at a higher risk of insulin resistance, ongoing hyperlipidemia, high blood pressure. And if they were to conceive again, they're also at a higher risk of recurrent adverse pregnancy outcomes. So it's really important that we have these conversations with them, but largely shared decision-making is so important as well, because as it stands right now, we have so many different options out there, many of which have not been studied during pregnancy, but the ones that have, or the ones where we feel we've at least removed the strongest of strongest recommendations and labels to not utilize them, perhaps we should be utilizing in our highest risk patients. So let's review our clinical vignette again. So if you remember, we have a 20-year-old Black female. This again is her first pregnancy. She's at 12 weeks gestation. Her BMI is 20. She has irregular menses and a very, very strong family history of premature CAD. Based on her lipid panels, I, of course, would be concerned about some sort of genetic predisposition, but even beyond that, hearing her family history, I'm also concerned about that. So when I thought about what I would do, number one, I would want to actually review preconception labs. And again, I put if available, because oftentimes they never are, especially in a 20-year-old. I will counsel this patient on diet, review exercise adapting to pregnancy, and most importantly, I will screen her for, starting as early as 12 weeks gestation, adverse pregnancy outcomes. I would consider, of course, talking to the obstetrician about the implementation of ways to decrease adverse pregnancy outcomes, preeclampsia being the largest one, and that could be in the form of a low-dose aspirin, as I talked about. That could be in the form of the Mediterranean diet. That could be in the form of ongoing physical activity. And then I would suggest that we measure her lipids the second trimester, monthly within the third trimester, but most importantly, with ongoing follow-up in the postpartum. And then if these measures continue to get higher and higher and higher, this is where that shared decision-making is important, where we would have discussion about, should there be initiation of lipid lowering therapy? Right now, I think, again, more data is needed, and probably more of a focus on lifestyle measures are needed as well, but at least we have this sort of baseline to help guide us. So in terms of my take-home points for today, the management of maternal supraphysiological hypercholesterolemia does present unique challenges for physicians and clinicians that are caring for women. And I think it's important to acknowledge that the care for these women are across the lifespan, because again, preconception is such an important part, but what occurs during pregnancy does impact their future life up to even 40 years after this adverse outcome. Lifestyle therapies, including heart-healthy diet, exercise, are truly the foundation of management, but sometimes there will be the need for prescription medications. We know that they are largely discontinued a minimum of 1 month and possibly as long as 3 months before conception. And in women who are pregnant or breastfeeding, we know that discontinuation of statins and other lipid-lowering therapy do warrant shared decision-making, particularly in those highest risk cases, those with ASCVD or FH. In the case of unintended pregnancies, discontinuing lipid-lowering therapy with immediate consultation with clinician is, of course, suggested. Though again, the risk of complications to date appear low, I think it just highlights the fact that more research is needed on this. During the already stressful time of pregnancy, these women sometimes are left with difficult decisions about balancing their own health with the potential risks to their children. And against this backdrop, the data regarding safety of statins and other lipid-lowering therapy in pregnancy, it is evolving, but they are still lacking. And for me, I know I sound like a broken record, but it highlights the broader issue, which is that the current approach to research in pregnant women, and most importantly, the enrollment of pregnant women in clinical trials, is very limited. So I think we have to acknowledge that. We have to acknowledge that we do need to hold a lot of these pharmacotherapies accountable for data on safety, efficacy, should dosing changes occur, because as we even saw in the Cardia trial, perhaps having a total cholesterol too low could actually be, can result in a negative impact as well. So I think it puts us in a very complex situation, but I would say that the kind of the positive beyond this is that at least there are some guidances out there that helps us to identify these highest risk patients earlier, so we can have that shared decision making with them and really figure out what is the best way to best manage these patients. So I thank you for the opportunity. This is my email if anyone has any pertinent questions, and I would be more than happy to open it up for discussion now as well. I'm going to stop sharing my screen.
Thank you so much, Dr. Bond. That was fabulous. Once again, I got more information this time than I did the first time. I have a quick question for you. And once again, everybody, you can send questions through the chat or unmute your microphone and ask directly. Out of curiosity, is there an ICD-10 code for maternal supraphysiologic hypercholesterolemia?
That's a great question. I actually don't know the answer to that. I will be able to find the answer though for you, so I can get back to you. But I would say if there's not, there needs to be. I will say that largely we see severe hyperlipidemia or severe hypercholesterolemia. There's always oftentimes ICD codes for that. Again, the limitation is that there are several reasons why we don't always have ICD-10 codes when it pertains to maternal health, just because it's still a growing field. And as a result of that, we may not necessarily have that. But I don't know the direct answer. My inclination is there's not, but there should be.
Well, thank you. I appreciate that. I agree. It took us forever and a day to get an ICD-10 code for FH as well. So, and when you were talking about adding statins, is it a kind of common practice to, if you're going to put them on the statin, maybe the first trimester, take the statin away and add it at the second trimester on and with breastfeeding? Or do you usually have them stay on it through the whole pregnancy if they're high risk?
Yeah, so if they're high risk, it's suggested that it's continued through the entire pregnancy. The recommendation again would be transitioning it to a more hydrophilic statin, one that has less transplacental ability and capability. And we would still monitor their cholesterol levels, because the concerns that I raised are that oftentimes are the cholesterol levels too low? And will that impact both mother and fetus depending on how she progresses throughout the pregnancy? So the recommendation would be during the pregnancy that we would be continuing it. But again, this is where shared decision making is really important. I have had a few cases where through shared decision making, and this of course was in guidance with the maternal fetal medicine specialist, that because our patient had FH and already evidence on calcium scoring that there was a high burden of calcification at a very young age, that the risks of withholding statins were much higher than the risks of continuing it. And as a result of that, it was continued. And she did fine, baby did fine. But again, this is where you have to have that explanation and be very clear in terms of the fact that we now know the FDA has removed the category because there's not enough data to support that it can have teratogenic effects, but theoretically they can occur. But again, we have to weigh risks versus benefit. And this is where shared decision making is really important.
Thank you. Appreciate that. We do have a question on the chat. Excellent presentation. Is there a directory to find a high-risk OBGYN that can help co-manage young high-risk patients?
Yeah, so I would say that from a national perspective, oftentimes I also volunteer with a organization called the Preeclampsia Foundation. And although it's specific to preeclampsia, they obviously have directories of the obstetricians who are the highest of high risk, because a lot of times women who have preeclampsia are seeing MFMs and high risk providers. I will put their website in the chat, because they actually have a directory of physicians who they felt all across the United States are highly impactful in helping in terms of decreasing rates of preeclampsia and cardiovascular health. So they also provide a fund of knowledge outside of just cardiometabolic risk factors, but you know, they do a lot of advocacy, and I think it's a really amazing organization. And it was created by the current CEO, who actually had preeclampsia herself. So she wanted to have an organization that could be the voice of many of these mothers who have no idea what to do oftentimes, because sometimes even us as clinicians and physicians have no idea what to do. And this is why education is so important. But I think the Preeclampsia Foundation would be a good resource.
Great. Thank you. I appreciate that. So we don't have any more questions in the chat. Does anybody have any questions? You can unmute your microphone and ask Dr. Bond your question.
Hi, Dr. Bond. Hey, was a nice presentation. I'm Sawan. I'm one of the cardiologists here in Birmingham, Alabama. And my question was, so when you use statin in your high-risk patients, do you start with the low dose, or is the side effects are dose dependent? And what are the commonest things that you have seen, so that we can educate our patients? You know, this is what you may have, like, as a worst situation.
Yeah, so absolutely. So ideally, they would have already been on statins coming into the pregnancy, and the recommendation would be to switch them to the equivalent. But again, if they were not on a hydrophilic, switch them to the equivalent of that hydrophilic. There's no data, again, to kind of say what dose should be started, if you should go low and then titrate up, because again, there's no data to say that women during pregnancy may be more inclined to have adverse outcomes or side effects. But I think it's important to acknowledge that we still have to continue to track their cholesterol levels. I think oftentimes what I see is that patients just continue, or not patients, but providers continue the medications, and then they just don't check again their cholesterol levels. not understanding that the natural effects of pregnancy are going to oftentimes even double their total cholesterol or increase their triglycerides, and perhaps the dose that they were on before going into the pregnancy may not be enough. So our guidance should be that we're actually reaching levels, the same levels that we're recommending, and we're treating at the same thresholds that we're recommending outside of pregnancy as we would inside of pregnancy. So for FH patients, if our threshold is an LDL less than 100, that's what we should be striving for. And this is where checking periodically the lipid panel would be absolutely important. And I don't want to have all of you believe that this is a large portion of patients, because again, it's really specific for those highest of high risk patients. And oftentimes through shared decision making, those patients do not want to take the statin, and that's okay. But we do need to advise them that data is now supporting that even that brief period of 9 months, if they decide to not have lactation thereafter, can actually impact their cardiovascular health in the future. And that's where we have to become more comfortable in giving patients options and helping to guide them as best as we can. So to answer your question, we would put them on the same equivalent dose that they were on, hopefully leading into the pregnancy. Make sure, though, it's a hydrophilic statin, and then continue to periodically check their lipid panel to ensure that they're maintaining the recommended and being treated to the recommended threshold that was suggested outside of the pregnancy.
We have a couple other questions on the chat. How concerning is low cholesterol at conception? Was this just one study that was looked at?
Yeah, so this was a very large study, and it was not just one study. It was just actually one of the more, I would say, kind of profound studies that are now giving us opportunity to explore and research this more. So what they saw was that there was a connection between mothers having premature labor. What we need to do is, again, do more studies like this, because this study, although large and really was the premise of this topic of discussion, again, warrants more studies, and probably larger, even larger than 1,000 patients that they looked at. So then we can actually say, well, if it does lead to premature labor, is it possible it leads to other adverse pregnancy outcomes? And if so, how low should we feel comfortable going, particularly if we're keeping patients on statin therapy? One person in the chat had asked how to delineate high risk, and FH in of itself, irrespective of, again, LP(a), again, this is very subjective, but FH alone is deemed high risk. Of course, those who have existing atherosclerotic cardiovascular disease, specifically those who have presented with a requirement of having stent bypass surgery. And as I made mention of, it's within the 4 months of that acute event, unstable angina, acute coronary syndrome, right? Those patients within the 4-month window, the higher risk, but again, it could include those who have existing ASCVD as well. And this is where we do need to do a better job and demarcating what should we do with these patients? Because as I mentioned, moms are having children later on in life. So we may be seeing more mothers that have higher rates of ASCVD just because they have higher rates of cardiometabolic risk factors. And then to make it easier for us, guidelines should tell us, what should we do? What is the right thing? Right now, what they're saying is it should be shared decision making based on patients who have FH and based on patients who have known ASCVD, specifically if the event occurred within 4 months of when they now are deemed to be pregnant.
Wow, lots of great information, and certainly with our screening programs for women, this is, you know, one way of getting them in and screening and being able to navigate some of these FH patients and high-risk patients. We're coming to our closing time. I want to thank you again for a wonderful talk. Thank you for the resources you were able to give us, and for also being a strong supporter of the National Lipid Association. And so it was great to meet you and talk with you. And thanks everybody for joining us. And I will talk to y'all at the next CLIS Speaks.
Thank you so much. Have a good night.
Good night.